Great. Well, hello, everybody, and welcome to the Hennepin-University Partnership Webinar Series. Today's webinar is titled Partnership in Practice, Co-Developing Dementia Outreach with the African Immigrant Community, and is presented by Dr. Manka Nkimbeng. My name is Margaret Stumbo-Turvey, and I'm a Senior Project Manager with the Hennepin-University Partnership. The Hennepin-University Partnership is a collaboration between Minnesota's most populous county and its only land-grant university. At HUP, we're dedicated to catalyzing and supporting mutually beneficial relationships. The partnership has led to over 500 joint projects, combining academic research and local expertise to inform policy and practice for the benefit of county residents. The goals of this webinar series are to offer information exchange and showcase research. We hope today's session is both accessible and informative for people with varying levels of familiarity with the topic. Before we get started, just a few Zoom reminders for our audience. Your video and audio are not enabled, so if you need any support from the HUB team, please feel free to use the chat. If you'd like to ask a question, you can submit that through the Q&A function. We'll monitor questions throughout and save time to address them at the end. Today's webinar is being recorded, so please look for an email from hup@umn.edu with a survey and a link to the recorded webinar tomorrow. And finally, I'm so glad to welcome and introduce the presenter. Dr. Manka Nkimbeng is a nurse scientist and a faculty member at the University of Minnesota. She holds a PhD in nursing from the Johns Hopkins School of Nursing, an MPH from Boston University School of Public Health, and a Bachelor of Science in Nursing from the University of Massachusetts Amherst. Over the past 5 years, she has worked with African and Black immigrant communities to develop culturally appropriate dementia education and outreach programs. In partnership with communities, she develops and tests culturally relevant interventions that can be translated into health policies and clinical practice to improve health and reduce health disparities among older adults. And I'll turn it over to our speaker now. Thank you.
Thank you so much, Margaret. Good morning, everyone. Thank you all for having me today. And so I'm going to share a little bit about the work that we've been doing with many community partners in Minnesota over the past 5 years. And so it's literally a story of what we found, how we did the work, and who we worked with. And then at the end, I'll share a little bit about kind of the lessons learned. But I'll start with a little bit of background. So for those of us who work with older adults, we know that the older adult population is growing in diversity and that the immigrant older adult population is actually really growing fast in the United States. But despite that growth, studies on dementia care, especially in these communities, immigrant communities and other minoritized communities, are very limited. And then we also know that dementia and care interventions programs, apologies, are developed in partnership that have often been developed in high-income countries with white adults, primarily male and also in English-speaking persons. But like I was mentioning, the immigrant population in particular is growing, but the older adult population in general is really growing in cultural diversity related to race and ethnicity, gender, immigrant and refugee status, as I mentioned, and then also their experiences are also very diverse. So many are experiencing inequities and health disparities related to social determinants of health, racism, cultural diversity, and kind of like all of the other factors that tie into many of these factors. And then we've found that to improve access to many of these programs that we're developing, we need to ensure that the programs are being tailored for those subcultural groups that are going to be receiving the interventions. We also need to consider the cultural context of the recipient, not only in the development, which is a tailoring of the programs, but also in the delivery of the programs. And that often includes the practice of cultural humility. And then the final thing is that we don't also only do those two things, but we actually involve the recipient community in the development and design process of those interventions and programs that are going to be used for those communities. So I always want to pause and talk a little bit about what culture is, because a lot of the work I'm going to be talking about is related to designing culturally responsive or culturally appropriate interventions. So a definition that I typically like to use is one that was given by Dr. Deward Anderson from the University of North Carolina. And she defines culture as an ever-changing set of shared symbols, beliefs, customs that shape individual or group behavior. So that's the definition of culture I carry throughout the work, and we've used in our practice here at the U of M in the work that we're doing with the community. But in addition to that, we know that this culture is learned because it's transmitted from generation to generation. And we found that culture is learned through the interaction with others who share those cultures, but oftentimes it actually exerts its effects on people's internal beliefs and behavior. So it's internal, and then they express it in different ways. And I'll show an image a little bit shortly about what exactly I'm talking about. And then the other thing that it's important to recognize about culture is that it's not static. It's created, it's adapted by kind of what is happening cognitively, emotionally, resource-wise, and contextually. And so it's very important to realize that culture changes over time with generation and as things change. And so broadly speaking, culture is actually often referred to kind of like in two phases. What we see, which is happening on the outside, so it's typically related to food, festivals, flags, clothing, music, and this types of things that we can see and hear from the outside. But that's just a tiny bit of culture. And much of what is happening, like I mentioned, that is internal, is happening beneath. So those are things that are deep culture things. So communication styles, notions of courtesy, respect, friendship, concepts of self, time, past and future, all of those things are internal and they are considered deep culture. And these are things that you cannot just observe. You actually have to engage in a conversation with those who practice that culture to be able to know what these deep cultural aspects are. And so what I'm going to be sharing primarily today is the work that we've been doing with the African immigrant community around developing a culturally tailored dementia education program for the community. And so a little big background before I go into this project. This project was the second in a series of projects that we've done with the community. And the very first one was the needs and access assessment that we did in partnership with the community. And dementia education was identified as a need. And so along with our community partners, we sought some funding to develop a culturally tailored dementia education program with the community. And this is what was called the African Immigrant Dementia Education Project. And the goal of that program was to develop culturally tailored dementia education for the community. And it was done in partnership with ACER, which is African Career Education and Resources, Inc. It's a nonprofit that primarily serves African and Black immigrants in the Northwest suburbs. So we work in partnership with that community partner. We had a project advisory board that was a 20-member project advisory board that included many, many diverse practitioners, leaders, and stakeholders in the community. And then also we had a team at the University of Minnesota that included a research team and other student volunteers. So we sought funding for this project together, and we worked on the project together as well. So specifically, the three goals of the project were to create an African immigrant health professional advisory board to inform the cultural tailoring of the education program, and then conduct focus groups and key informant interviews to really think about what do we include in the program and how do we tailor it for the community that we're developing it for and with, and then develop the education program and a booklet that would go with that education program. So, like I mentioned, we had key informant interviews with about 10 community leaders, and we also had 4 community conversations with numerous community members to kind of ask their perspectives, like I mentioned, about what should be included in the education program, and more importantly, how do we develop it and structure it in a way that is culturally tailored for this particular community. So I'm going to share a little bit about the findings from these first phase of the project, which was the key informant interviews and the community conversations. So a little bit about some of the leaders that we interviewed. We had executive directors of nonprofit organizations, we had administrators, we had community health strategists, we had priests, and we have people from different African countries that were represented in the area, which is the northwest suburbs of Minneapolis. And then a little bit about the age. 2 of them were over the age of 61. which is the older adult community. And then many of them were first-generation African immigrant. First generation basically means you were born outside of the US and then you migrated to the US. And then many of them were from the countries that are represented in the area. A little bit about their religious background. The majority of them were Christian. There was one Muslim, and then one of them actually was currently caring for someone that was living with dementia. So I'll share a little bit about kind of the themes that we got from those conversations. These are not all of the themes. I'm just giving you example themes to then talk about how we carry the themes from that conversation into an education program. So the very first thing that came up was faith beliefs in the community. So these are 3 examples that were described by the key informants and community participants for the community conversations. They said there's a belief in the community that prayer will heal all conditions. There's also a belief in the community that there's no healing outside of God or Allah. And then there's also a belief related to some certain faiths that avoids the use of different types of health products, such as blood, contraceptives for different faiths. And so we asked them, whenever they named some of these things, we asked them, how do we approach it in an education program? And so they said, you want to name them in the education program with the community, but you want to discuss it during those sessions to talk about how dementia is not related to those conditions or above and beyond. For Christians, they mentioned the idea of faith is important, but people also need to seek care for dementia. So it's really having that conversation with the community participants to talk about, really have a discussion about the different faith beliefs, and then talk about how healthcare and health seeking within the medical system for a condition like dementia is also important. Another thing that came out was stigma. And so when we did a deeper dive to understand kind of where stigma was coming from, we found out that there was kind of 4 themes that were related to the stigma. One of them was a limited understanding of the condition in the community. And so it was kind of that idea of, if you do not know what something is, then you're kind of afraid of it, or you associate other things to it. The other thing that was related to the stigma was kind of the personal or family denial that somebody has dementia. Another thing that was related to the stigma was fear of sending a relative to some sort of residential setting, which such as a nursing home or assisted living. And the final thing that was related to stigma was this idea that dementia is normal aging. And again, like I mentioned in the previous theme, we asked them, how do we approach this in an education session? They mentioned identify each myth and then debunk it with relevant medical facts and also evidence-based facts. So we took all of that information and then developed an education program. And the next couple of slides are going to be example slides from the education program and booklet that we had. And then I'll also describe what we did in the community and the results of the education program too later down the line. So when the education program was developed, there was a need for a name. So several names were suggested, and African Made was the one that was voted upon by the community, the project advisory board, and other members of the community. We did a poll and sent it out to the community, and people voted on African Made, which stands for African Memory and Dementia Education Buy-in for the African immigrant community. And if you do community-based participatory research, you know that it's very important to identify who was part of the creation of any initiative or work that you did. And so immediately on there, we talked about being co-created by the Immigrant Memory Collaborative, the community partner, and the advisory board. This is something that was very important to recognize people who are part of the process in any intervention or program that we're creating. And so the very first kind of part of the education session was actually sharing why we were creating an education program specifically for the African immigrant community. So this is a picture of a slide from the education program, and it talks about the project that led us to this one, which was the African Immigrant Memory Loss Project. And so we share a little bit about the composition of the leadership of the project, which is very similar to this one. And then we'll share a little bit of findings from that project that was very relevant for the creation of this education project. So there's 2 bar graphs below. The one to the left shares about how cultural perspectives affect African immigrants getting care for someone with memory loss and dementia. And then the bar graph to the right shares a little bit about the dementia knowledge test that we did as part of the needs and access assessment that basically showed that the dementia knowledge in the community was very, very limited. So it really necessitated the creation of this education program. Then this is another example slide from the education program. Remember, I talked a little bit about the myths and the stigma and the fake beliefs that were influencing dementia care and caregiving access to support. So they told us identify all of the myths and then debunk them. So we have all of this on a slide, and we go through each one of them, and we have participants have a conversation with us about them and really talking about why dementia is not normal aging, like the myth that people are just old, like the myth that dementia happens to everybody, or the man proposes but God disposes, which is kind of the fact that, it's just going to happen and there's nothing that you can do because it's God's will, or for the Christians and for the Muslims, it's Allah's will. And then a little bit about the myth that dementia is related to witchcraft. So this slide often leads to lots and lots of conversations amongst the education participants when we get to it in an education session. So this is an example slide of how we discuss the myths with the community. And then when we discuss that, we now get to really talking about what dementia is and get into this image of showing people what is happening in the brain for someone that has dementia. And we show this slide of the Alzheimer's type of dementia. And so we also have a robust conversation with the education participants about what is really happening in the brain of someone who is living with dementia, and really saying that it's not witchcraft, it's not a curse, and it's not all of those kind of myths that participants might have brought with them to the education session. And then another slide was talking about the unique barriers that African immigrants face in accessing care in the United States. So these are some of the ones that we found in the needs and access assessment that we did with the community. So we go through each of them and really talk about what it means for the community. For example, the very first one, experiences with healthcare in Africa. Many Africans don't primarily seek preventative care or have annual physical exams as part of their general healthcare practice back home in Africa. But we know that in dementia, it's very important that the older adults are getting those annual physical exams. They're getting cognitive screening at those physical exams so we can understand the trajectory of their cognitive health. So that's something that we talk about. While back home, you do not go seek preventative care or get an annual physical, but in the US, it's very important that an older adult is doing that. And so we go through each of those things that are relevant for the community and discuss them with participants to ensure that they understand the differences between seeking care back home in their countries of origin in Africa and then seeking care in the United States, and really how it's important for improving either dementia risk factors or just improving care for a person living with dementia and other cognitive impairment. And then the other thing that also is important in the community is caregiving. So before we get to talking about caregiving, we often have a conversation about the cultural beliefs related to caregiving for the African immigrant community. And so there's many expectations related to caregiving for Africans. These are some of the ones that we've heard from the community. Our parents took care of us when we were younger, so it's our time to take care of them. That's often the general one, but different countries have actually different, more specific beliefs and expectations. So we see some people saying that daughters have the responsibility to care for their parents or grandparents, the last born son, the richest, the eldest. And so we have this conversation, and it's when we do have this conversation, we get into the place of talking about what if the family expectations are not met? So we have families where it is the expectation that a last born son is caring for a parent that is living with dementia, but maybe that last born son is not in the US and the parent is in the US, or maybe that last born son is somewhere else and the parent is somewhere else. And so we have this conversation and really help the education participants to think about how their cultural expectations might be mismatched with current caregiving circumstances, and then help them to think through what do they need to do now to ensure that the person living with dementia is getting adequate care and quality care, and then the caregiver themselves is also taking care of their own health. So that's the conversation that starts the caregiving part of our dementia education program. And so we developed that education program and the booklet, and we've offered that education to, I believe, over 50 different groups right now. We partner with many, many community organizations, and basically the structure is a community organization, a church, a mosque, a cultural group can just reach out to any member of our team and invite us to come offer the dementia education to them. And during our pilot phase, we're collecting pre and post surveys to explore how knowledge change was happening after the dementia education program. So now I'm going to share with you a little bit about some findings from our pilot education phase. So our pilot involved about 67 participants, and many of them were within the age of over 60, which is a good thing. And gender was, there was no big gender differences, no big educational differences. And we found that there was quite a few past caregivers within our samples, and also a few current caregivers who were coming to our education session. And then many of them had some professional experience caring for someone living with dementia. And we divided it by first generation, which I mentioned someone was born outside and migrated to the US, and second generation is someone who was born in the US to parents who were born outside of the US. But that was a really small part of our sample, especially in the pilot phase. I think these are the most important kind of findings. We found out that as expected, the more education people had, maybe a little more dementia knowledge that they had, but these findings were not necessarily statistically significant. Again, it's a very tiny sample that we're sharing, so just take that with a grain of salt. And then, but we find that by education level, the baseline dementia knowledge was slightly higher, and the more education you had, the more kind of dementia knowledge you had baseline. But everybody kind of improved in their dementia score post the education session. So the education was supporting everyone, people who had less than high school education to people who had a graduate degree for the most part. Then the other thing that was also interesting was kind of people who had some sort of professional experiences with dementia. We find out that the education was also informative, even for people who had professional experiences of caring for someone with dementia. And typically, many of the professional experiences were related to being a certified nursing assistant, a nurse practitioner, and or home health aide. Those were the primary professional experiences that we found. And then obviously the main kind of effect that we're hoping to find, the difference in before education knowledge and post-education knowledge. We found that the dementia education slightly improved dementia knowledge and was significantly different from pre to post. So that was a good thing. So our education program is indeed improving dementia knowledge for attendees of this education session. But I think what was also very interesting was kind of the qualitative or the comments that participants were telling us about the education session. They really liked it. It was very informative. And they talked about how the presenter was using simple terms. They talked about how the education was very educative. And this idea of, I'm going to be sharing it with friends and family was something we heard. And many of those friends and family were not actually people living in the US. People were talking about gaining this dementia knowledge and then sharing with their friends and family back home in Africa. And this was very important because we had quite a few distance caregivers in our sample, people who were supporting someone that was living with dementia back home in their country of origin. And so this dementia knowledge was really helping them. And there was one participant that was saying that time was short for the session. Mind you, most of these sessions are lasting over 2 hours because, again, there's a lot of conversation built in around the faith beliefs, around different practices, so that participants are able to share their perspective and then kind of have a conversation with the facilitator and also with others who are in attendance at these education sessions. So the education basically showed quantitatively that improved dementia knowledge, and we found out that the attendees were also enjoying the sessions. So we've been doing this. The dementia education started in about 2022, and we piloted and The pilot ended in 2025, and now we are in full phase of dissemination, and we're offering the education to everyone in the community. And I just wanted to pause and share some key considerations that are important in this kind of work that we've done, and some of the things that really facilitated our success or our work to move smoothly with the community. So the very first one is really building and maintaining trust with the community partners and with the community. And I think there's a model of engaging with the community that we've practiced with our team. This is the engage model, and the N stands for network, which means you gain, first initial networking session with a community partner or the community. And then the very next thing you're encouraged to do is not ask any questions about research or take anything from them, but is giving. And this giving is very, very general, which you can give resources, you can give time, you can just attend community events. Members of our team have attended community partner events and have just helped to clean up after the event or even go before and set up. So giving is not necessarily monetary. And then once you give and you're building that relationship, you can now think about advocating for research, and it's really having a conversation with our community partners to say, this is who we are. We're researchers from the University of Minnesota. We have this dementia education project that we're doing. Might you be interested in? And if they say yes, then maybe you can proceed to do that work with them. If they say no, you continue giving and giving back to the community, and then you evaluate towards the end. So all of this is very iterative, and it's very different for different community partners. So you're continuously having the conversation, networking, and giving. The goal is to ensure that you're not just taking from a community, but that you give as you take whatever it is that you're taking from the community. I know researchers typically, we think about the work that we're doing is really supporting the community, but also we're publishing with the community. And so that's something that could be benefiting us as well. And as healthcare practitioners, it's different. We want to support and offer education to the communities, but the communities do not know us yet. And so giving is a good way of really ensuring that you're trying to build trust with those different communities that you want to go in and offer education or offer screening or whatever it is that you want to interact with the communities. And this model has been very successful on our team because that's what we use. And that giving, it's one of the things that community partners are like, we like that you showed up and you didn't ask us to do research the very first day. So that's something that we've learned as part of this work. The next one is really ensuring that you're hearing the community voices as part of the project. And I had shared the name Immigrant Memory Collaborative when I talked about how we named our education program. And this Immigrant Memory Collaborative name actually came when quite a few of our community partners were telling us that they're getting confused with the numerous projects that we had. We had the needs and access assessment, and then we had a dementia education project, and they're like, maybe soon we'll have a third project. Are we continuously going to be calling the different names of each project? Can we just find a name that talks about all of the group of projects that we're working on together so we don't get confused? So that was a suggestion that came from the community. And then again, we had different names nominated, and we did a poll, and the Immigrant Memory Collaborative was the name that was chosen. And so this is the name that really encapsulates all of our group of projects now. And we don't have to keep going back to the memory loss project, the education project, and whatever project we're doing. That's something that really came from kind of listening into the community. And that's a name that we found out is very useful. When people hear immigrant memory, it's like, oh yeah, that makes sense, that we identify as immigrants, and you all are talking about dementia in the community. And then that's also the other thing that helped us organize a party. When we developed the accompanying dementia education booklet, like I mentioned, that was one of our goals. Our goal was just to start printing out copies of this education booklet and bringing them out to the dementia education events that we were having in the community. And our community partner said, no, you can't just do that. You need to actually have a launch event to launch the booklets. And so that's us at our launch event, where we had a huge celebration event, food, brought community partner and guests together to launch the booklet. And you can see everybody was happy because they're all smiling in that picture. So really trying your best to listen to the community partners that you're working with, to, as best as you can, implement the strategies that are suggesting. I know with budget constraints, something like that could be challenging, but again, we just do the best that we can as researchers, as program planners, to work with the community and support the community. And then the other thing that we found that was also very useful was using some of the documented or evidence-based strategies that have been documented in the literature. I think one of them was partnering with trusted gatekeepers and community partners. And so our dementia education was developed with primarily one community partner, but we've leveraged their network to now offer the education program to many, many other community partners. And then obviously, when we go to a community organization, we're talking with the leader of that organization. And once we have a good rapport with the leader is then able to introduce us to members of that community or that church. And so we're now able to go in and do dementia education. And oftentimes people are trusting us because they trust their leader and their leader has introduced us to them. So those strategies, I think they've already been documented in the literature. And so it's just for us as program planners and researchers to implement some of those strategies. And then the last lesson learned, or the last key consideration, is to recognize that the process itself could be a service to the community. And I brought in two quotes that our team has received from research participants, actually, about the process that of collecting research. So the quote to the left is from a care partner who was interviewed for a dementia caregiving support intervention that we're developing. And basically, the care partner was identifying that just the process of us on our team asking them questions and listening to them was comforting to them. And we know that for care partners of persons living with dementia who are so stressed and could be suffering from caregiver burden, just having a listening ear could also be supportive. And then also, many of us, when we go out to do education or to do programs in the community, we're typically bringing resources from our offices or resources from other relevant community organizations. And that is something that can really benefit the community. For example, whenever we're going out to do dementia education, we're bringing brochures, booklets, and different phone numbers for different caregiver support programs in the community so that the people who come to this education session are able to get resources. And so just the work that we're doing in being in the community could be a service and is a service to the community. And oftentimes we don't recognize it. And if we recognize it, maybe we can do it in a more intentional way to really think about, we're going out to this particular community, what kind of other resources can we bring with us so that we're ensuring that we're making that event a one-stop shop for those who are attending that kind of event. So I'll end with a couple of key takeaways. Cultural humility is very critical, even for us who, I'm African immigrant and several members of our team are African immigrant. We do not know all African cultures. And so it's always very important to take that stance of continuous learning and asking questions. For example, when we were going to work with the masjid, there was no member of our team that was Muslim. And so we had to have a phone call with the leader that we had been working with to kind of just have say, what should we do and what should we not do? Because our goal in going in is to offer dementia education. We do not want to do anything that is offensive unintentionally to the community. And so it's pausing to ask those questions, which is that practice of cultural humility. Then the next thing is really thinking about building community. So thinking about, if you're a researcher, a community of researchers that are doing this work so that when you're going into the community, you all can go at the same time, or community of practitioners, a community of healthcare providers, so that when we go to the community, several of us are going in at the same time and we're offering as many resources as we can to that particular community when we go out. Same thing for the community organizations. Like I mentioned, we've leveraged our primary community partner because they have multiple other community partners and organizations that we work with to offer this dementia education program that we've been doing in the community. Then the last thing I would highlight, which is one of the things we learned as part of this work, is celebrating milestones. I think some of us, we might not even recognize the milestones, or we might not recognize that things are milestones for the partnership that we're working with. So it's listening to the community, and when we can, celebrating milestones and celebrating whatever wins that we we've developed and we've gained along the way, which is very, very important in building trust and ensuring that people are actively still kind of motivated and passionate to do the work that we're partnering to do. And this is one of the things that we were able to celebrate when we were approached by Sahan Journal to talk about the dementia education program that we had done with the community. So that's myself as a leader of our team with the executive director of our primary nonprofit organization that worked with us to develop the education. And if you think about it, this news story is more important to the community partner than necessarily a journal article that we publish. The journal article is important for the researchers, but not necessarily important for the community partner. So it's really thinking about ensuring that we're making sure that each partner is winning along the way. And this is something that we did and celebrated this win for both ourselves and also primarily for our community partner. And all of this work would not have been possible without the funders. So I just want to pause and acknowledge them. The education program was funded by a pilot grant from the Johns Hopkins RIGMA. And then my time on the project was funded by the Bob Kane Endowed Chair at the U of M and an NIH K01 award. And also the education program support activities were funded by the Northstar Geriatric Workforce Enhancement Program. And you all know that we need funding to do this work, so we want to acknowledge our funders. Then I wanted to share a couple of resources that might be useful to some people in this group. Is the community-based participatory research that we have at the University of Minnesota. I teach that course, and it's really talking about some of the strategies that we've used in this work. So we share a little bit about those over the course of the semester with the attendees. And I want to highlight that this is a class that actually has both University of Minnesota students and community partners. And so by late fall, we'll be advertising this class for community partners to actually attend. And there's a handful of scholarships that community partners can have to attend this class. And so I share a couple of resources that we have published as part of doing this community engaged work. And then the last thing I'll share is the kind of the third project in the line of projects that we've been doing. The very first one was the needs and access assessment. Dementia education was the first need. The second need was this idea of how do you support the current care partners, people that are caring for someone living with dementia right now. And so we on our team have adapted an evidence-based care partner intervention. Again, very, very similar structure, working with the community to adapt this program. And now we're recruiting participants to be a part of this, testing this program. So I just shared the flyer in case you know any people who are accessing your services that could benefit from this type of care partner support program that we have developed. And this is the QR code for anyone to join the study, or they can just reach out to our team and we'll be able to talk with them about the project. And I want to end by really, really thanking those who are involved in this work. So many people that I cannot name by name. So really appreciate our project advisory board members. We've had 2 project advisory boards so far, so it's about 30 plus members on that project advisory board. Many, many key informants, many, many community conversation participants, and many, many community partners. This is just a handful of the community partners that were involved in the pilot phase. We haven't even added any of the newer ones now in the dissemination phase. And obviously all of the participants and people who are taking our surveys and attending the education events, because without them, this work would not be possible. So I think I'll end there and we can have a robust conversation.
Yeah, thank you so much for your presentation. So I will open it up to the group. Please put any questions in the Q&A function, or you can also use the chat, whatever's easier. While we wait for questions from the group, I guess I just wanted to ask, I know something that is probably relevant both for university audiences as well as county audiences, is interacting with a group who may have kind of worked with researchers before, or worked with somebody from the institution before. And yeah, I'm curious if you could speak to maybe combating prior experiences if a community feels like they have lost trust with an institution. I'm curious how much, if at all, that showed up in your work.
Oh, I think it does show up. And then it's a little bit of using the engage model that we talked about. First, having the conversation. I actually have a community partner that I'm working on repairing the relationship with them right now. And I've been working with them to do this for over 2 years. And it's really the very first time was she's a female executive director. She did not want to see the U of M because she had bad history with the U of M. And so it was really for a while, I just attended their events in support. I really love advocate for the work that they do. So I attended their events in support. Again, that was that networking that I was doing. And then after a couple of times, she was like, "You've been here a couple of times." I was like, "Sure. Can you share exactly what happened with your previous experience at the University of Minnesota?" And so she shared, and it's indeed a sad experience. And so it's really acknowledging with them that that was wrong, and then talking about, I'm not going to rush you to partner with me to do research. It's just, I think the work that you're doing is important. I advocate for the kind of work that you're doing, and I'm here. If you ever needed to partner to do any kind of research or any other things, I'm here. I hope I would do it differently because we never, you never are definitive. We try our best to do things differently. But again, I say all of this knowing that as researchers, we have various constraints around budget, timeline, and IRB, and so many other things that oftentimes it's not necessarily the researchers' fault. It's the other constraints that they're living within that then leads to destroying a relationship. But I know I'm committed to transparency and making sure that whatever decisions are made are being made transparently. And so that's what you can commit to as a researcher, to say, I'll be transparent with you, whatever we have to do, how we do it, we're going to discuss it together. If it's a budget shortfall that we have to work towards, together we'll work towards it. Whatever it is, we'll work towards it collectively and transparently. I think that's very, very important to do.
That makes sense. Thank you. Let's see. So I haven't seen any other questions come in the chat. I'll just reiterate to the group that we certainly would welcome any questions. Let's see.
Comments are also welcome, so it's not just questions.
Yeah. And I will say we send out the recording afterwards. And if you're willing, we can always share slides as well. So I know sometimes we'll have follow-ups after. So we did have more people register who were able to join today. So oftentimes people will watch the recording later on YouTube, and we welcome that form of engagement as well. Not seeing any questions. I'll close us out for today. I just want to say thank you again. I'll put a feedback form in the chat for our guests. But yeah, a huge thank you to our presenter for sharing your time and research with us, and thank you to all of our guests for joining us. If you have a moment to fill out the feedback form, HUP would love to know more about your experience. And you can register for future webinars. We do have one comment I'll end on, which is just really appreciated the research approach and care taken. So many lessons learned and key insights applicable for different areas in community engaged research. I agree. So thank you again, Dr. Nkimbeng. We really appreciate your time, and thank you to our guests.
Thank you all so much. Again, if you're a community partner organization that is interested in having our team come offer our dementia education, please just reach out to our team, and we're happy to come offer that education to the community. It's no cost to the community partners. So.
And I did just see one question come in. I know we were just wrapping up, but I'd love to ask it since we have a couple moments. Sure. Someone asked, is anyone developing a list of providers, neurologists, speech language pathologists, et cetera, who are culturally knowledgeable / humble?
That's not the first time we're hearing this question. Our team we're in the very, very early phases of trying to do that work. But the challenge is that there's no official registry of many of the domains of culture that might be important to think about. And so it's something where we've just been doing this kind of, we've heard from other caregivers that this person was great with us, and so we're keeping track of that kind of information. But just because there's no official registry and there's also no criteria to think about, is it languages access, is it evening hours, and all of these things that are very, very important for caregivers. There's no official registry that we can just go search and say, these are the types of providers that meet this criteria. So it's a slow process where we're just keeping track of what we hear when we get into community. And it's a very small list right now. So
Yeah, good question. All right. Well, thanks everybody again, and have a great rest of your morning.